Okay, so in this chapter, in chapter 48, we'll talk about the neurobiology of psychotic illnesses. And the first one we'll talk about is schizophrenia. Schizophrenia literally means split mind, and it's a split or separation among normally well-synchronized brain functions. And therefore, this results in thought, behavior, and feelings that are disorganized, disordered, and disconnected from reality. And we call this a psychosis if it's disconnected from reality. Now, it's characterized by altered perceptions of reality as well as disordered thinking. And it was first diagnosed between, the ages of 15 and 54 years of age. Women typically have later onset of diagnosis, 25 to 35 years of age. Men have typically a little bit of a younger onset, 15 to 25. And women typically have better outcomes than men with respect to the schizophrenia. Now, in terms of the clinical manifestations, we have positive and negative symptoms. The positive symptoms of schizophrenia include reality distortion and disorganization. And the reason why they're called positive symptoms is they reflect excesses or distortion of normal function. Now, this comes from excessive dopamine D2 receptor activity. And what we find then are delusions, which are basically systematic, fixed, and false beliefs. And these typically have themes. These delusions can result in themes of persecution, like someone believes that the CIA is out to get them. Delusions of reference or somatization. Somatization would be, a delusion where somebody believes that there's a mind control device, implanted within their brain. Or delusions of religiosity relate to, sort of a religious theme where someone believes that they might be able to, have contact with the deity, or maybe they are a deity. There's also delusions of grandeur or grandiosity, where someone believes that they're, maybe the master of the universe, or a celebrity without any sort of reputation, or delusions of controlling. Now, the positive symptoms also relate to distortions in perception, and we call these hallucinations. Now, hallucinations are basically sensory perceptions with no apparent stimulus, and these can affect any sensory system. We typically think about hallucinations as affecting the visual system, and yes, that's true that some hallucinations can be visual. However, there are also auditory hallucinations where people can hear noises or words that don't or aren't actually there. There's olfactory hallucinations, so for smell, gustatory hallucinations of taste, and tactile hallucinations for touch. Now, auditory is the most common here in terms of schizophrenia, and people will describe how they hear voices or there's different sounds. Now, with these hallucinations, we see disorganized thinking and speech. Now, this disorganized thinking is sort of characterized by frequent derailment or loose associations. We also have invented words that people will use and tangential ideas where they seem to be very disconnected, and the logic behind the flow of their conversation seems to only make sense to them. And when most severe, you get incomprehensible speech. If you have invented words and lots of tangential ideas, over time, or at least if it's severe enough, that speech could be incomprehensible. Now, what's important to note, though, with the positive symptoms of schizophrenia is that these individuals have just excesses in normal functioning. And this can come with disorganization, but they're able to communicate fairly well. They can move fairly well. And if you didn't communicate with them, you might otherwise assume that they're, healthy. Now, we also see grossly disorganized behavior in positive symptoms as well. And this disorganized behavior can range from childlike silliness in adults all the way to unpredictable agitation. And all of these can impair the tasks of daily living. If you have so much childlike silliness that you can't even drive a car or, go run errands or hold a job for that matter. That's going to lead to impaired tasks of daily living. Now, we may also see catatonic motor behaviors, and this is where you see a decrease in the reactivity to environmental events, where if there's a loud noise, they don't flinch. And it might be to such an extreme that they can maintain a rigid posture and resist efforts to be moved. So someone might switch, into a catatonic state where they're so rigid and they just stay put that they can't be moved to their room or from their room to another place. And these can come and go. So catatonia isn't necessarily permanent, but they might, find themselves in a catatonic state at some periods of time. Now, this is similar, but also very different from the negative symptoms of schizophrenia, because these negative symptoms reflect more of a decrease or a deficit in loss of normal functions. Remember, the positive symptoms are in excess of normal function. Negative symptoms are typically more characterized by a decrease or deficit, hence the name negative. Now, these are considered to be restricted, and we'll see a restricted affect. So affect refers to sort of the inflection of your vocal tone, and a restricted affect would be speaking like in monotone. Now, avolition and asociality are also characteristics of negative symptoms. Avolition means that they sort of, don't have control over their own body, or at least appear not to. And asociality means that they don't seek out social contact. Now, this is associated with dopamine D1 receptor activity. That's different than the positive symptoms, which relate to D2. So D1 receptor activity relates to these negative symptoms. And the manifestations of the negative symptoms include things like social withdrawal, isolation, dull or blunted emotional affect, poverty of speech. We'll see, changes in posturing, as well as autism, in the sense that individuals will be, lack eye contact, not seek out, social contact either, and be very fixed on certain tasks. Now, in terms of the clinical manifestations here, we see impaired higher cognitive functioning, also problems with attention and long-term memory. We see problems with working memory, abstraction and planning, and language comprehension and production. This is why it's the negative symptoms, because you see deficits in all of these sort of higher order functioning. Now, other manifestations, again, remember, include emotional affect. It can be blunted, shallow, or flat. It can also be inappropriate or silly. So what we see then is sort of extremes here, where it's either extremely lacking or sort of exaggerated here. And what I mean by this in terms of emotional tone is someone might be talking about a very emotional thing in their life, but they'll talk about it in a very blunted and shallow, flat way. They might talk about how the close relative recently died, but there's no emotion behind what they're saying. But it can also be inappropriate or silly, where they might be talking about a close relative who recently died, but they're making a joke out of it constantly, and in a way that seems inappropriate or silly. Now, we also might see a loss of emotional tone, and we see this it's characterized by unchanging or inexpressive facial expression, lack of eye contact, few gestures, or maybe no inflection in speech. And this correlates with anhedonia, which is an absence of pleasure or interest. So individuals with the negative symptoms of schizophrenia may feel little pleasure from otherwise pleasurable experiences, where things that maybe used to bring them pleasure, like fishing or maybe painting or playing a musical instrument, these no longer bring them joy. So we call that anhedonia. Now, we can diagnose schizophrenia in a variety of ways. It's characterized by two or more of the following symptoms. So what we need then are delusions. And delusions are really the hallmark here, where there's a disconnection from reality. With these delusions, we might see things like hallucinations, disorganized speech, grossly abnormal psychomotor behavior, maybe even some negative symptoms as well. And at least one of these should include delusions, hallucinations, or disorganized speech. So, there's a longer list to diagnose schizophrenia, but these are sort of the big ones here. But remember, delusions are a disconnect from reality. Hallucinations are a perception of stimulus with no apparent stimulus. And disorganized speech is essentially just, it's hard to explain, just disorganized speech. And we see a significant disruption in work, interpersonal relations, and self-care as a result. Now, there do appear to be some genetic effects with schizophrenia. What we find then is that if you're a child of two parents that are schizophrenic, you have a 40 to 68% chance or risk of developing the illness with respect to the general population. So if both your parents have schizophrenia, you're 40 to 68% more likely to develop schizophrenia than the rest of the population. Now, there are other developmental factors, though, and you'd think that if both your parents had schizophrenia, if it were purely genetic, you should see a higher risk with that. So what we understand then is that there's probably environmental triggers as well, and some of these appear to be developmental, like prenatal infections. There's actually some evidence that prenatal influenza puts you at risk for schizophrenia. So if your mother was sick with the flu while she was pregnant with you, then you're more likely to develop schizophrenia versus the rest of the population. It can also correlate with things like malnutrition, other birth complications, and brain injury, and these seem to increase the risk as well. Now, in terms of the gestational effects, we actually see structural changes in the brain of people with schizophrenia. Now, normally in our hippocampus, which is the learning and memory center of our brain, cells line up like a picket fence, and these are the pyramidal cells that are involved in learning and memory. So they should all be, structurally layered and lined up like a picket fence. What we find, though, is that if you're exposed to influenza in the second trimester, this increases your risk of developing schizophrenia. And instead of having this normal picket fence type of arrangement of cells in the brain, or specifically the hippocampus, they appear to be more disorganized. And not surprisingly, later in life, this leads to more disorganized behavior. Other hypotheses have focused on impairment of hippocampal functioning as well. And some of the neurological effects of schizophrenia relate to neural development. So we see changes in the limbic and prefrontal regions. Remember, your limbic system is involved with sort of emotional processing, and the prefrontal regions are involved with higher order functioning, things like reasoning, logic, morality, judgment, personality, so that these are actually altered in development. And studies of the brain reveal abnormal limbocortical structures and misarranged hippocampal pyramidal cells. We also see altered glucose metabolism in the frontal lobe. And so all of these are structural changes that are observable in schizophrenia. What's not totally clear, though, are these causational or correlational? Did these structural changes occur before schizophrenia and therefore cause it? Or are they a consequence of some other mechanism at play? But these are things you can look for in terms of diagnosis. So we also see larger than normal lateral and third ventricles because of a loss of gray matter. The ventricles enlargen to fill up that missing brain space. We also find fewer nicotinic receptors in the hippocampus, which could also explain why some people with schizophrenia like to ingest nicotine. And we also see abnormal blinking and pupillary reflexes. This also basically suggests an underlying issue with the brain. Now, pharmacological treatment of schizophrenia relates to drugs that target dopaminergic receptors. So remember, dopaminergic receptors, this variety, D1, is associated with the negative symptoms, and we see that clozapine is used to block D1 receptors to help with the negative symptoms of schizophrenia. And remember, D2 related to the positive symptoms of schizophrenia, and we see that this is sort of the receptor that's targeted by these atypical antipsychotics. Now, new medications that are coming out on the market aim to stabilize rather than reduce dopamine activity. That way you can kind of bring them into a sort of a normal baseline and then work from there. Now, other non-pharmacological treatments of schizophrenia aim at sort of case management and helping individuals improve their activities of daily living. The most efficacious treatment is the least restrictive setting as possible. In the past, we'd thought that putting individuals within insane asylums where there's very restrictive settings and it's almost like a prison, was a good option. But what we found is that individuals with schizophrenia actually perform better with less restriction. It's I guess a way to put this is more of it's like a structured, unstructured type of environment. Well, where they're allowed to engage in more degrees of freedom, but with boundaries. Now, this helps to optimize their quality of life and social functioning. And cognitive behavioral therapy is effective here. And this is where you basically sit down with a client and basically work through their negative beliefs, and this actually helps to improve their basically their outcomes. Now we see social skill-based therapies are effective as well, so just helping people stay engaged with other individuals. Vocational rehabilitation, we're going to help train individuals in a certain skill, and that way they can at least sort of maintain or lead a normal life. And family therapy is effective as well, where individuals maintain close contact with their families, and they're part of their family unit, and they feel like they have a role in the family. They have better outcomes if that's the case. Now, major depressive disorder is a totally different disorder here, and this requires the presence of multiple symptoms. And as it sounds, it is a depressive disorder. So it's enough to cause distress and persistently impair psychosocial functioning. It may develop as a serious secondary illness or complication, and some of the subcategories here include dysthymia and SAD. Dysthymia is depression with one or more symptoms that last 2 years. And SAD is seasonal affective disorder, which is a seasonal pattern of depression, typically with the fall and winter months. Now, we diagnose major depressive disorder by experiencing 5 or more of the following criteria within the same 2-week period. So it must also represent a change in previous functioning. So these can't be how someone normally is. There has to be a difference in how they normally behave. And at least one of these symptoms need to be depressed mood or loss of interest and pleasure. So in terms of what these manifestations are, we see they've got to have 5 or more of these, and that includes fatigue, restlessness or irritable agitation, impaired concentration, low self-esteem or feelings of worthlessness, negative thinking and sleep disturbance. And this could be hypersomnia, which is basically excessive sleep, or insomnia or lack of sleep, appetite disturbance, which could be either weight gain or weight loss, psychomotor retardation or agitation, so changes in psychomotor activity where they might have more of a blunted sort of affect or hyperactivity here. And psychosis may be present in severe cases. So in individuals who are severely depressed, psychoses can result where they have sort of a disconnect from reality. Now, we find those that these are sort of a side category. However, individuals need to feel depressed or have a loss of interest. So these are the hallmark symptoms here. Now, these are sort of other things that can co-occur with this depressed mood or loss of interest. And in children and adolescents, we may see this as an irritability rather than a loss of interest. So that's something to consider. Now, in terms of the etiology or neurobiology of major depressive disorder, the causes of it remain unknown. However, we see that cognitive behaviorally or psychologically, individuals with major depressive disorder typically have negative views of their self. They might be excessively hard on themselves about their own personality or their body image, and they also have negative views of their own life and their future. Now, neurobiologically, we see that there's changes in neurotransmission. So we see neurotransmission dysregulation, as well as altered hippocampal and prefrontal cortical cell structure functioning. There's also seems to be hypothalamic pituitary adrenal system activation. And if you guys remember from anatomy and physiology, this HPA axis was part of your sympathetic nervous system. So we've seen that they might be just overly sympathetically active, and this puts them in sort of an extended stress response. Pharmacologically, we use antidepressants to treat major depressive disorder, and these improve things like norepinephrine, serotonin activity. We see that it typically takes 3 to 6 weeks for improvement. So people think that if you take a pill, you're going to see improvements immediately, because that's typically the experience that individuals have with drugs. However, with antidepressants, it might take 3 to 6 weeks for improvement to result. Now, we use different types of antidepressants. There's monoamine oxidase inhibitors that they actually block norepinephrine and serotonin destruction. And if you block the destruction of these neurotransmitters, they stay in the synapse longer and therefore have a stronger effect. We have tricyclics, which block the reuptake of norepinephrine and serotonin. So instead of blocking their breakdown, that just blocks their reuptake. So again, they stay in the synapse longer. There's also selective serotonin reuptake inhibitors, or SSRIs. These just prevent the reuptake of serotonin, therefore it's staying in the synapse longer. But we also have SNRIs, which are serotonin and norepinephrine reuptake inhibitors. Again, these help improve the length of time that these neurotransmitters stay in the synapse. But you find that the common theme between all these drugs is that they all affect the concentrations of synapse neurotransmitters, and the idea being here that they're going to have a stronger effect if they're in the synapse longer. Now, with SSRIs, what we can find is something called Serotonin Syndrome. This is a serious side effect that results from excessive serotonin activity. This can lead to altered mental status, restlessness, agitation, myoclonus and hyperreflexia, sweating, shivering, tremor, GI upset, ataxia, and headache. And so this is sort of a consequence of serotonin overdose. And so, people who are depressed think, oh, if I'm feeling particularly sad, I should just take more of my antidepressant. And unfortunately, that's just not how they work. So they can overdose on serotonin if they're maybe taking too much of it rather than their recommended dose. And it can lead to these particular signs and symptoms. But other side effects can include sexual dysfunction, which could be either a loss of interest or impaired arousal, or anorgasmia, where individuals can't achieve orgasm. But it can also cause GI upset, headache, allergy, dry mouth, constipation, urination difficulties, sweating, and significant weight gain. So you want to make sure that people are aware of these side effects, and you can become depressed about these side effects. So it's important to know if someone has these. That way, you can help to reverse serotonin syndrome. Other non-pharmacological treatments of depression include ECT, which is electroconvulsive therapy. This is essentially a type of therapy where individuals are hooked up to, basically high voltage electricity, and you're basically running current through their brain. It simulates an epileptic event, and for some reason, this seems to improve mood. However, this is a last resort because there's a lot of complications with this, and it's very invasive because you're essentially shocking someone's brain. Now, there's also phototherapy. We see that light exposure, especially UV light exposure, helps to improve mood. So if someone has a seasonal pattern of depression, or maybe for whatever reason they're indoors a lot and they're not exposed to natural sunlight, we can mimic this with 10,000 lumen intensity full spectrum white light box exposure. And this is useful for seasonal affective disorder. But even just 30 minutes a day of direct facial exposure to this type of light can help improve mood. Now, cognitive behavioral therapy is effective, as well as interpersonal therapy. And these are behavioral therapies that aim to help prevent the relapse. And when used in conjunction with pharmacological therapy, they actually have the best outcome. So not just giving someone a drug, but giving someone a drug for the depression, but also working through maybe some of the negative views of their self, their future, their own life, and helping to improve the way that they view the world, and that's going to improve their outcomes better than just drugs alone. Now, bipolar disorder is on the spectrum of these depression disorders, but it's basically characterized as recurring symptoms of depression and elation that can become severe enough to produce psychosis. Remember, psychosis was that disconnection from reality. And mania is the hallmark symptom of bipolar disorder. Now, mania is sort of an expanded or elevated sense of mood and self that can lead to reckless behaviors. And when initial symptoms of mania are significant to produce psychosis, bipolar can be mistaken for schizophrenia. In fact, bipolar and schizophrenia seem to share a lot of the same etiologies because they have a tendency to co-occur. So if you have a family history of schizophrenia, bipolar is more likely to occur, and vice versa. So in children, it can present as irritability or cyclical mood changes, and it can be often associated with attention deficit hyperactivity disorder because ADHD is also correlated with other psychological disorders. Now, we can classify bipolar disorder as bipolar 1 and 2. And bipolar 1 is where we have at least one episode of mania, as well as major depression. And bipolar 2 is that there's no episodes of true mania, but we'll have hypomania and major depression. So think of bipolar 1 as having more extreme ups, that's the mania, with depression. And bipolar 2 is where there's not as high ups or these manic states. In fact, it's hypomania because there's no psychosis. But there is still major depression that results. Now, hallucinations and delusions can occur during the psychosis that can correlate with mania. So people in their manic state actually may have hallucinations and delusions. Now, mania is this abnormally and persistently elevated, expansive, or irritable mood. So what we find during a manic episode is that people have an inflated self-esteem or grandiosity, and with this you see self-appraised importance, claims of limitless expertise, even though there's nothing to back that up. They might have insulting put-downs, and this can actually really reach delusional proportions, right? Where people in their manic state think that they possess the ability to do anything and conquer, any task. But it's delusional because it has no connection with reality, In their more severe examples, they may believe that if they, move their arms fast enough that they could potentially fly. Now, other manifestations of bipolar disorder include things like a decreased need for sleep. We see increased talkativeness and pressure to keep talking, a flight of ideas or subjective experience that thoughts are racing. We have distractibility or increased goal-directed activity. And people with bipolar disorder appreciate this particular part where in their manic state, because they have increased goal-directed activity, they're able to have, essentially increased productivity in social, work, school, or sexual realms. But this also correlates with psychomotor agitation, which can basically, limit their activities of daily living. Now, excessive involvement in pleasurable activities is also what's characteristic of mania. And this isn't to the point where, someone might just, watch TV because they like watching TV. But rather, this is to the potential that someone may actually produce harm to themselves, right? So there's excessive involvement of pleasurable activities that have consequences that can be long-term, painful, and these can be things like unrestrained buying sprees, where someone believes that, in their manic state that, that they'll be able to, make $1 million within a week. So why not just go out and buy, a new home or, a boat on credit without really thinking about the consequences of that. We also see that this correlates with sexual indiscretions, and this can increase the risk of, STDs and other social aspects related to that. Now, the difference between hypomania and mania is that they have a difference in severity and duration. Hypomanic symptoms persist for like 4 days or more instead of 7. Hypomania also doesn't include the psychosis or impairment in functioning. So what we see is that with hypomania, there's a sudden onset of increased energy, expanded self-esteem, also decreased anxiety, and the individual might believe that they have improved productivity and like a natural high. And because of this, people kind of get addicted. They actually like this state of mind. Who wouldn't want to have increased energy or expanded self-esteem or a decreased anxiety, especially if it improves your productivity and you feel like you have a natural high. So it's difficult to approach people in their hypomanic state, even their manic state, to get treatment for bipolar because they typically like how they feel then. Now, in terms of the etiology and neurobiology of bipolar disorder, we see that there's a higher risk of developing this disorder if it runs in your family. So there seems to be genetic factors here. However, in identical twins, if they share the same genes, one twin may develop bipolar disorder and the other one might not. So there seems to be environmental triggers as well. Now, neurotransmission activity deficits promote depression symptoms, and excessive activity seems to promote the symptoms of mania and psychosis. So we find that it's a sort of a dysregulation of neurotransmission, where we have basically altering states of hypoactivity and hyperactivity, and that correlates with changes in someone's personality and mood. Now, we see impaired emotional processing and impaired regulation of emotional behavior, and these are probably neurobiologically related. Pharmacologically, what we can do is actually help to, treat with antidepressants, and these can help improve their major depression there. And we want to also understand how much mania or psychosis is occurring as well, because mood stabilizers may be more significant if they have bipolar 1, where they have true mania and psychosis. So things like lithium and anticonvulsants, as well as atypical antipsychotics, can help stabilize their mood and prevent, major depression and true mania. It kind of it keeps their mood in a more stable state. Non-pharmacologically, what we can find is individuals that undergo cognitive behavioral therapy and family-focused treatment are less likely to relapse, and therefore have just sort of better outcomes. So remember, cognitive behavioral therapy is aimed at essentially talking with a client and helping to work through their negative views or basically their illogical reasoning. And we have family-focused treatments as well, because having a family support system is helpful to improve outcomes. And it's much easier to engage patients during their depressive cycles than mania, because people don't like to feel depressed, typically. So that if they're in the depressive state, they're more likely to want to seek out treatment. However, people like to feel good. So if they're in their manic state, they're less likely to want to reverse that, because mania is associated with a lack of insight and motivation. Now, in terms of just gender differences, what we find is that women are twice as likely to suffer from depression and anxiety disorders as men. There's a likely biological basis between the vulnerability between men and women. However, there seems to be social aspects as well. Things like marital status, work roles in society, and exposure to sexual abuse, as well as physical violence, can put someone at risk for mental illness. Now, because women are more likely to experience sexual abuse, as well as assault and physical violence, they're at a higher risk for mental illness. And it could also relate to other social aspects, such as, it's more appropriate and socially acceptable for women to discuss how they feel than men to discuss their feelings. So this actually may relate to a difference in diagnosis rather than a difference in prevalence. Now, there do appear to be some gender differences in the hypothalamic pituitary axis as well as serotonin receptors, and this also could relate to reproductive hormones. So there are some gender differences, though, between mental illness diagnosis rates. It's just important to keep in mind that women are twice as likely to suffer from depression. Now, other cultural considerations is to take into consideration as well, as you guys, is that what we find is that cultures around the world view mental health in different ways, right? Depression, anxiety, they're viewed in different ways. They might be revered and feared in different ways. And it's important to consider someone's cultural background when approaching these mental health disorders. Now, a disorder in one country might not be considered a disorder in another, because they have sort of a cultural definition here. So there's different cultural-bound syndromes, and they're just terms that people use around the world to describe different forms of mental illness. And there's an interesting wiki page. If you guys just Google culturally bound syndromes, you'll come across this Wikipedia page that lists all these culturally bound syndromes. And if you actually happen to have a DSM at home, you can look at this in the index. But essentially, they're just a list of disorders that are common worldwide and relate to cultures. So some of those can include things like, in Southeast Asia, there's one called running amok, where running amok is just all of a sudden someone will have these bouts of severe anger, and they actually start to have aggression and start to attack people. There's one in the southern United States. It's called fainting syndrome, and it's essentially just where people overcome when they're overwhelmed with anxiety or excited, they'll faint. So these are just different culturally bound syndromes that are important to consider. In terms of geriatric considerations, we see that psychiatric admission for older individuals is more geared towards major depression, and not so much with other psychotic illnesses. Major depression is much more common in the elderly, and it's extremely rare for bipolar or schizophrenia to emerge after age 60. Now, the elderly are more likely to suffer side effects from antipsychotic medications, things like tardive dyskinesia, which is a movement disorder that results from these antipsychotics. And antidepressants are prescribed at lower dosages because of the way that their bodies handle these drugs, and therefore they're titrated upwardly more slowly to avoid these negative side effects from these kinds of medications.